Hi, it's Dr. Centeno, and thanks for joining me today. I'm a little bit later than I usually do this on Sunday. Had some responsibilities earlier in the day. Let's see. Today we've got a really good topic. I'm going to be talking about styloidectomy and how it impacts craniocervical instability. You can see from my background here that I'm trying out different things. This is actually a picture of the research lab in our practice. We've got a full-on university level research lab as well as a processing lab. This is the research lab. Just a background, since I'm doing this from home, but it is our actual research lab. So I'll be trying different things here. Previously, I had a light problem behind me in my office at home, so trying to solve that as well. Today, again, we're going to be talking about styloidectomy and its impact on craniocervical instability. As usual, you can ask whatever questions you want. I'll do a short presentation, and then we'll go and start into the Q&A section. Again, today's topic is about styloidectomy if you're just joining us, and its impact on craniocervical instability. So we'll get started on that. Let me share my screen here. Okay, let's start here. Well, maybe I should just go share a window. Hold on a quick second here. Okay, so we will get started here. Slideshow. So the topic today is how does styloidectomy impact craniocervical instability, or CCI, or just cervical instability in general. These are the references for today's topic. So a couple things here. I mean, the first is we can see the styloid process here coming off just underneath the ear from the skull. And then you can see that there is a stylomandibular ligament, a ligament that actually goes from that styloid process to the mandible. There's also a stylohyoid muscle that jacks into this whole strap muscle complex up front here. And frequently, the solution for Eagle syndrome is to go in and cut that whole thing out. Basically, everything that connects into the styloid process. So the concept behind Eagle syndrome is that you have these elongated styloids and you're getting compression of the internal jugular vein, 12th, 9th, vagus nerves, other things. And there's compression between these elongated styloids and the actual front of the cervical spine here. And that's the upper cervical spine. Now, obviously, if you've got instability, that's making all of this worse because these bones here that make up the back of that wall aren't stable and keep pushing into things. And then you've got these elongated styloids. Now, here's the problem with Eagle syndrome, and that is 4 to 7% of everyone walking around out there who doesn't have any symptoms at all has an elongated styloid process. And we know that 96%, or say that again, 96% of those patients have no symptoms. Only 4% of those patients with elongated styloid show symptoms. So that's the problem, right? If we had this 100% correlation, or even 90% or 80% or 70% correlation between elongated styloids and symptoms, then cutting this styloid out might make some sense. But since it's such a small population, only 4% of people with elongated styloids actually have symptoms, now all of a sudden, really, it's kind of a lotto ticket, right? We've gone from, if we do this surgery, we can make this person better, to we really have no idea if we do this surgery, this person's going to get better. Now, maybe we can up those odds a little bit by looking at certain specific things, like saying, well, we think your symptoms are related to one of these structures that could be getting compressed. So maybe that ups the odds a bit, but it probably doesn't up them over 50-50 because we're starting out with the odds only being 4%. So that's the problem. And the other problem is that you've got Eagle syndrome symptoms in here, and then you've got craniocervical instability symptoms over here, and there's a huge overlap between those two. So it's hard to tell the difference between these two just based on symptoms. And obviously, styloidectomy is a big surgery, right? It's an open surgery. They've got to go in. They've got to cut the styloid. So obviously, you can always get a localized infection. You get trigeminal neuralgia, damage to the nerve that causes more face pain, vascular injury because there's blood vessels in there. In that very vicinity, you've got the internal carotid artery and all of the little blood vessels that come off of it. You've obviously got the internal jugular vein. All of those things can be injured. You've got other nerves running through there that can be injured as well. And realize that the styloid is an anchor point for the skull into this anterior neck stability system. So we've got all of these muscles up front here, the sternocleidomastoid, the sternohyoid, geniohyoid, all these others that jack into this hyoid bone and that provide stability in the anterior neck. So there's also that stylohyaloid muscle that's part of that. So if we cut the attachment for that, it makes sense that we're going to get increased instability because that anterior stabilization system isn't going to work as well. Same thing with this stylomandibular ligament that goes from the styloid process to the mandible. And that's why we see a lot of CCI patients get TMJ, right? These anterior strap muscles that are supposed to not stabilize that on the neck on a moment by moment basis get recruited to do that because the small muscles that are supposed to do that job high up and that go from segment to segment can't do it anymore. So these muscles get recruited to help. And then you start getting additional forces on the TMJ. So it really doesn't take a rocket scientist, right, to say that if we take that styloid out, we're going to be increasing anterior cervical instability a certain amount, meaning that that's not a vestigial thing. Those ligaments and those muscles have specific purposes, and those purposes are to assist with stability and in many ways act as a secondary stability system when the primary upper cervical stability system is offline. And, here's how this usually goes, and this is why I'm talking about this today, is I will either usually get this question, should I have my styloid removed before I consider doing something like a PICL procedure or getting an upper neck fusion or whatever it is to treat CCI. Or it goes the other way where I've already had this done. It helped some things. It didn't really help most of what I have. So I'm still disabled. I now have figured out I've got craniocervical instability. Can you help me? And the answer to both is I probably could have helped more before the surgery. So if you haven't gotten the surgery yet, my recommendation is to stabilize the upper neck first. And if you've already gotten the surgery, there's not much I can do there, meaning I can't put that anterior stabilization system back together. So my recommendation is if you haven't pulled the trigger on this is just reverse the order of these procedures. Rather than doing the styloidectomy first, go to stabilize the CCI first. And again, this is in patients that likely have some element of Eagle syndrome and some element of craniocervical instability, or one is probably predominating over the other. No one really knows until one or the other gets treated. So in summary, elongated styloids rarely cause symptoms. A styloidectomy can cause more CCI by destabilizing the anterior neck control system. And if you think you may need a styloidectomy, I'd really recommend that you try stabilizing your CCI first, and then you can always get the styloidectomy, meaning that you can always get that styloid and its associated ligaments and muscles removed, meaning nothing about working non-surgically to stabilize your CCI is going to back you into a corner, but you can get backed into a corner if you've ripped out all of that anterior stability system, and then you go ahead and try to stabilize your CCI without that stability system being present. Okay, well, let me see if we've got questions. I'm sure we do. Got a bunch of people watching, which is great. Let's start out with Jessica. How can someone tell the difference between, let me stop sharing my, how can someone tell the difference between Atlas subluxation complex and CCI or AAI? Yeah, great question, Jessica. I don't know that there's an easy way for a patient to tell the difference, meaning that, what'll happen a lot is that we'll see CCI patients go to see an Atlas orthogonalist or a NUCA chiropractor. They'll do pretty well, but only get temporary relief, and then they end up on our doorstep. Now, realize that it can also go the other way, right? You can have an upper cervical misalignment. I've seen that in patients before. They go to the NUCA chiropractor. The instability is really not the driving component. There may be a little bit there. Eventually it all heals, we're able to get stronger, and they never look back. So I would say that for us to want to get involved in trying to stabilize your upper neck via injections, you're going to want to make sure that you fail NUCA or AO type realignment. Jessica, what's the measurement on upright MRI that shows you have CCI? There's a bunch of them that we use, clavoaxial angle being one, grab oaks being another, translational BAI being a third. So there's a bunch of them that can be used. Jessica, how should someone judge whether they should seek PICL procedure or they should seek out a fusion surgery? I think it starts with the telemedicine consult, going over all the information to, number one, see if CCI is causing the problems or likely to be causing the problems, and then to see what type of injection procedure might be appropriate, if any, or do you need to skip directly to a surgical fusion, which happens as well. But that's how all that process starts. AT, hi, Dr. C. I know you said nothing special for thoracic MRI, but any specific instructions further can help provide best details. Don't have any specific instructions other than go with the highest field magnet you can find. I would say that upright open MRI has particularly bad or very poor thoracic imaging. So I'd skip any open magnet or upright magnet for thoracic spine, and I'd go directly to a closed bore magnet, at least 1.5 Tesla. If you can get a 3, that's great. Elvin, can emotions such as laughter, sadness, adrenaline trigger symptoms if you have CCI? Not through any mechanism of which I'm aware. Franco, how do you diagnose facetoarthritis of the neck? Do you need imaging? If yes, X-ray, CT, or MRI? Franco, usually MRI is the most efficient way to localize facet arthritis, but you can see it on X-rays. You can also many times palpate it, meaning the joint, the facet joint, will be bigger at that on that side at that level. But the most efficient way to do it is usually with an MRI. Elvin, can sleeping on stomach be a cause of CCI? No. Regenetics been advanced by John Gardner. If you have CCI, would doing traction at a chiro for a bulge at 5/6 be a bad idea? Yeah, most of our CCI patients aren't going to really tolerate vertical traction really well. Now, there's a small subset of CCI patients that have more vertical instability, and they might actually like some traction, meaning that they've got cranial settling. But most patients are probably not going to tolerate it really well. AT for CCI patients, do you sometimes reject the fascia covering around the skull beneath muscles such as occipital or such as occipital? Well, I'm not sure which muscle you were referring to there. There isn't an occipitalis muscle. Or does treating the CCI directly usually alleviate the severe tightness? I usually do both, depending on the patient's exam. So again, quite a bit is driven by history, imaging, exam. Those are the three things that have to line up in order to pick a target. Nicholas, I've had a styloidectomy and C1 transverse process. I had PICL in April 2024. Yeah, Nick, and if it was with me, you probably got the lecture on, I hope we can help, but you've been destabilized from the front, and I'm not quite sure if we can help. Nikki, hi, Dr. Centeno, do you recommend that patients treat lower levels of cervical instability prior to traveling to CC for upper cervical, PRP, PICL? A lot of that depends, Nikki, what's driving the bus, right? So this is a good conversation to have. What's the upper cervical spine look like when it produces symptoms? And what do lower cervical symptoms look like? Usually mid to lower cervical symptoms look like issues in the arms, pain in the upper back. That's worse when your neck is worse. Numbness and tingling in the hands, for example. Whereas upper cervical symptoms look more like headache, dizziness, imbalance, brain fog. So it really depends on which symptom set is predominating. And you have to be careful because the medical care system loves what I call the bright, shiny object system or bright, shiny object syndrome. And usually the bright, shiny object is what's on imaging. And what's easiest to see in really any or many middle-aged and older people is there's some lower cervical degenerative disease. And so that's where the focus goes, but you have to make sure that the symptoms match that. So the answer is if you have got upper cervical symptoms, then you would come to CSC. If it's more lower cervical symptoms, then I think get that treated first and see how that goes. AT, on average, how many treatments are needed for treating thoracic fascial injury, a potential sternocostal joint, rib instability? What form of Regen Med works best for these areas? Usually not many, 1 to 2, and a lot of it depends on what we're talking about. So for example, if we're talking about just fascial issues, then anything from prolotherapy to PRP usually works pretty well. Elving, can both the greater and lesser occipital nerves create pain in the eye? Are there now more nerves that can cause pain in the eyes? There are a number of different nerves that can cause pain in the eye. The occipital nerves can refer there. And a lot of it is trying to draw a direct connection because people are wired slightly differently. For example, there are connections between the greater and lesser occipital nerve. So it may not be so clear cut, but I think a good thing to do just at home is you can find the lesser occipital nerve merely by following up the sternocleidomastoid to the back of the sternocleidomastoid where it inserts in the skull. There's a little depression there. And obviously if you press there and you got pain in your eye, you know it's the lesser occipital nerve. The greater occipital nerve you can find because it comes out just on the side of the upper trapezius, and when the upper trapezius inserts on the skull there. So it's going to be more medial. So if you're putting pressure on any one of those sites and it's referring into your eye or recreating what's happening in your eye, then that's something to talk to the doctor about. Submitted advance by John. I've seen some YouTube videos of patients getting better with PRP and Prolo that severe overhang at C1, have a significant decrease in overhang after this treatment. However, the alar ligament was never treated. How could that be? Yeah, John, I think we've talked about that on this show before. As I've said, in our experience, it's only about a 1 in 5 chance that you could get that to work. So if we take 10 patients, for example, that have that C1, C2 sliding type overhang or a type 2B CCI, only about 2 in 10 patients will respond with just posterior injections, and it usually takes quite a few. But we've seen that work from time to time. My guess would be that there wasn't a lot of instability to begin with. And then the other thing you've got to be careful with, and I see all the time, is when the DMX is repeated, it's not repeated the same. So it has to be repeated to the identical angle of head side mending in order for you to be able to compare apples to apples. But as I've always said, it works about 1 in 5 times, or 20% of the time. So that's not zero. So you would certainly see people out there where they seem to get some relief if they're in that category. It's just not reliable, meaning, relief starts getting reliable when we more get into the 60, 70% of the time it works. When we're in the 20% of the time it works world, it's sometimes hard to justify. And I can't tell you how many patients I've seen. Let me go back to that question because I'm still talking about it. How many patients I've seen who have a certain amount of money to spend on all of this, and they've gotten with a clinic who told them that was going to work, and they're on their 8th, 9th, or 10th treatment, and most of that financial ability they had to get this solved has been gone, poof. And they're not much closer. They've been sort of told, well, you just need to do more, you just need to do more, you just need to do more. So be very careful with that, because we see that all the time. Talking to patients who are just left financially devastated because they tried something. They started with a little Prolo, then they're doing a little PRP, then they're throwing a little bone marrow. It's all posterior. By the time all that's done, they've blown through $30,000 or $40,000, and they're no closer to getting any better. So just be careful. Susie, what can happen if the joints get irritated due to, for example, a forced movement or a bumpy ride within a few days after treatments of the neck? I wouldn't imagine anything, Susie, if we're not talking about another injury. We're just talking about things getting irritated. Nothing should happen. Sophia, with the 7 out of 10 patients getting better data, is that verified by a third party? I don't recall being asked about my results after 2 PICLs. Yeah, Sophia, you should have been getting registry data. So if you or registry questionnaires to fill out, if for some reason you weren't getting those, I will put my email down here. Okay, I'm putting my email in the comments. So reach out to me directly. And if you haven't gotten any registry forms, then we will make sure that changes. Meaning you're supposed to be sent registry forms to fill out that would ask you questions about your outcome, complications, all of that kind of stuff. John, Centeno, why pain in the posterior lateral border of the knee is common in patients with lumbar nerve root impingement. Yeah, it's usually S1 nerve in the back because that's where the nerve goes. The nerve goes into the hamstrings, and that's the lateral hamstrings attachment into the tibia and into actually more the fibula, sorry. And then at the same time, that's also where the skin stripe goes down for that nerve, sometimes L5. So that's why those patients get those types of symptoms. Getting ready to come in a few weeks. I've been on stem cell formula to prepare for a year, but ran out now. Says item unavailable on Amazon. Anywhere else can I get this from ASAP? Best thing I can tell you to do is just call the office, and they should be able to ship you some directly from the office. Sophia, what percentage of bone marrow concentrated is mesenchymal stem cells or other type of stem cells? I've read reports that it's a small number. It's a small number, a small percentage, but quite a few cells. So all of this has been looked at in significant detail. So let's go through all your different possibilities of trying to get stem cells here in the United States. So you would have as one possibility your own bone marrow. So let me bring up, actually I'll bring up a good visual on this here, if I can find it real quick. Bear with me 1 second. I got to find this here. Here we are. Okay. So this is a good visual. Let me go to share this here. Okay, so this is a good visual. It's a good visual because there's this concept out there that somehow the umbilical cord products sold in the United States are stem cell products. They are not. This is actually a study done by our lab and Colorado State University Translational Medicine Institute lab. And what you see here up top are 5 umbilical cord products. 4 of these products are Wharton's jelly. 1 of these products is umbilical cord blood. And all white means no living stem cells at all. On the bottom, you see stem cell colonies from bone marrow, and those are all elderly people, female 64 years of age, male 64, male 65, female 66, male 73. So as you can see, all of these products above had claimed that they had stem cells. Again, you can see stem cell colonies in purple down here that are dyed. On top, you got no stem cells at all. So it's a classic scam out there that a sales rep selling Wharton's jelly, quote, stem cells to a doctor's office. The doctor buys it, not really knowing the science. He believes the sales rep. Next thing you know, the doctor is injecting stuff that has 0 stem cells in it at all, but the doctor believes it has stem cells. The patient's told it has stem cells. So that's a good example of a visual that is important to look at. Casey, hi, Dr. C. A CBCT report recently showed I have an ossified style hyoid ligament. I was wondering if you could explain what that is, the problems it would create, how it happens outside of PICL curve corrections, anything to be mindful of for it. Yeah, Casey, so number 1, it's a fairly common issue. And I think it's important to note that we don't really see elongation of the styloid. What we really see is usually ossification of the stylomandibular ligament that attaches to the styloid. And it's a common problem. There's nothing to worry about, meaning that at the end of the day, we have lots of people walking around. 96% of the patients with that calcification have no symptoms. So not something to be worried about. Now, listen, certainly if the symptoms look more like Eagle syndrome and you can't get rid of the symptoms by stabilizing the upper cervical spine, if there's CCI present, then you can go down the rabbit hole of trying to see, well, is that causing any problems in me? Which is always something to be mindful of. Regenics, mid-advanced by John, are any thoughts on V cells injected to the cervical spine for CCI? V cells really don't exist at this point. There was a good paper by Herb Wiseman and his lab out of Stanford about 7 or 8 years ago that showed that V cells didn't exist. So I'm going to go based on that science that whatever it is they're injecting, it's not V cells. So, but again, we get into placing the cells specifically in the ligaments. Susie, does it make a difference whether you use hypertonic dextrose, PRP, or stem cells in terms of degree of inflammation that you provoke? Well, so if we're talking about prolotherapy solution, which would be hypertonic dextrose, it's working through promoting an acute inflammatory response, giving you another bite at the healing apple. Now, PRP and stem cells are completely different. While PRP may cause some inflammation, it's not working through inflammation. It's working through a number of different mechanisms, one being the release of growth factors, which cause healing. Another being the release of exosomes, which can do similar things. And then stem cells working through a similar mechanism, but also in addition to that, the stem cells acting as a general contractor and then being able to differentiate into the bricks and mortar. So a little different. You mentioned vagus nerve irritation is a probable cause of lightheadedness. Wouldn't it be more sensitive vertebral artery with CCI? Not necessarily, no. I don't think that the vagus nerve is, for the most part, causing lightheadedness in patients. So I'm not sure where that came from, meaning most of the lightheadedness that I see in patients is actually more probably being caused by proprioceptive issues in the upper cervical spine. And then the least common thing we see would be vertebral artery lightheadedness. So while that's possible, the vertebral artery could cause that, it would be not real common in this patient population. Elving, what's the difference between CCI and ME/CFS? Are there any statistics on misdiagnosis? It's a good question, Elving. I think that there's sort of Venn diagrams that overlap, meaning that there's probably a significant chunk of the ME/CFS population, myalgic encephalitis, chronic fatigue syndrome, who have craniocervical instability as their cause. And then there's another chunk, a very large chunk of that population where the cause is something else. So I think that's the relationship there. Are there people on the ME/CFS side who have CCI and never get diagnosed? Yeah, it happens all the time for sure. Franco, would dextrose prolotherapy be contraindicated if you had facet arthritis in the neck? No, shouldn't be contraindicated with facet arthritis in the neck. It's been advanced by Stephen Lee, benefits of having a cone beam CT done pre-PICL. Not going to help me, but it's usually being done to help an upper cervical chiropractor figure out what the vector for adjustment should be. So from that standpoint, it can be very valuable, but from my standpoint, it's not going to be helpful in looking for instability. Ashraf, how much volume of stem cell solution does an anterior portion of C1C2 facet typically take? I understand it's quite big ligament. So anterior portion of C1C2 facet, I think we'd be talking about the facet capsule, not much. If you're hitting the facet capsule from the front at 1-2, a quarter cc, a half cc at most. Jessica, what do you think? I felt likely in a car crash when I hit a dip and felt my head suddenly came loose. Yeah, that's a hard one to answer, Jessica. Hard to say. May have been a ligament injury, may have been something else. Kimmy, could tightness of the styloid muscle or digastric muscle cause eustachian tube dysfunction? Yeah, I think you can get eustachian tube dysfunction through that mechanism. You can get it through CCI. So that's not uncommon that we hear things like that. Casey, I was hoping you'd expand upon curve correction. My understanding of curve correction outside of strengthening and relevant muscles is stretching the ligaments, put bones in the right place, but not be counter-regenerative injections. Thoughts on halo standing, active traction weights, or dinner roll. Dr. Rose would recommend to me avoiding traction instead of focus on posterior injections. Yeah, so I think there's a couple of different things here. When it comes to curve correction, the concept is that once we see straightening of the cervical spine, for example, you're getting more of the weight shifting forward into the discs, and the weight of the head instead should be pretty much approximately half on the disc, half on the facet joints in the back. So that by getting that curve back, we can help someone's pain. We can offload certain things like the upper cervical spine, like the discs. Now, I would say there's a good chunk of patients that I see with craniocervical instability that can't tolerate curve correction. And so they sort of self-declare themselves out of that box, if you will. And I think I've said it here many, many times. A great way to try to do that is, this isn't a towel. Well, yeah, this isn't a towel. It's an eyeglass case, but take something about this size as a small hand towel and roll it up. Experiment with the thickness, but put it behind your neck, right in the middle, lie face up on a firm surface, so it's putting some pressure anteriorly on the neck, and see how you respond to that. Some of my CCI patients will say, wow, that feels great, in which case you should definitely try curve correction. Other CCI patients will be like, nope, can't tolerate that. That is not for me, in which case you're not ready for curve correction. And what we need to do is work on tightening the upper cervical spine before that patient can tolerate that. Ashraf, if a ligament has repeatedly been injected with dextrose, bone marrow, or PRP, and then is re-injured, is absorption or flow in the ligament from further injections reduced and less likely to heal strongly again? Wow, that's a question with 1,000 offshoots, so it's a hard one to answer. Is it possible that the re-injury of a ligament could damage it such that it would be difficult to treat going forward? It is, but that's usually not the case. So that's probably the best I can answer that one as worded. Franco, what's the best treatment for post-traumatic facet arthritis in the neck if you had instability at the same levels? Prolotherapy, PRP, or stem cells, and which tissues, capsules, or joints? Well, usually the best thing to do if there's instability causing facet osteoarthritis is to identify which ligaments are lax, treat those ligaments, at the same time treat the facet joint. So that means you're going to need not simple kind of blind prolotherapy or even ultrasound guided prolotherapy. You're going to need a combination of X-ray guidance with contrast confirmation into the facet joints. Usually PRP works well there. Sometimes you need bone marrow concentrate, but usually PRP works well. And then you're going to also have to treat the ligaments, and usually that's through ultrasound guidance, focusing specifically on those ligaments. Susie, I read about potential platelet dysfunction in people with POTS. Is this a contraindication for PRP treatment? Susie, I don't know of any substantial platelet dysfunction in people with POTS that would be a contraindication for PRP treatment. But certainly, I think I put my email down there in the comments. If you find something in particular with a scientific paper that says X or Y, I'd be happy to look at it. But at this juncture, I don't believe that's a thing. Harsh, doctor, does the knee capsule heal after an injection or knee arthroscopy? Yes. Now with knee arthroscopy, you're obviously, it's a much, much bigger hole. So I think there would be a higher likelihood that the larger the size of the hole, the higher likelihood is that it wouldn't heal. Now there's still probably a pretty small likelihood that it's not going to heal, but and then if it's a smaller hole, like through a needle, a 25 gauge needle, the likelihood of that hole healing becomes much, much, much higher, more reliable, etc. Nicholas Black, I had one, made my CCI worse 100%. Are you talking? I think maybe, Nicholas, you're talking about styloidectomy, and that's not uncommon for me to see. It's been advanced by Ruth McGroarty, most effective diagnostic imaging tool and methods. I think you're asking about most effective diagnostic imaging tool for craniocervical instability, but please let me know if I'm answering this incorrectly. Most effective diagnostic imaging tool we have, as I always say, if CCI is present, the most likely thing to find it is digital motion X-ray. Then the next most likely thing to find it is upright movement-based MRI, and then finally a routine MRI. Harsh, sorry for the related questions. Do Regenexx physicians perform blind injections into peripheral joints? No, they should not. So if you find a Regenexx physician performing a blind injection into a peripheral joint, again, I think I put my email address down there. Definitely reach out to me, and that'll be a big problem for that doctor. MX Goon, I know it's been discussed, but no clear answer. If money is no option, assuming Atlas is holding, how much time between procedures is optimal for PICL and posterior PRP? Well, so a lot depends on symptoms. If your Atlas is holding, I'm assuming the symptoms have also gone down. If the symptoms have gone down, then you might not need another PICL treatment. If the symptoms have remained, then there may be other work that needs to be done. And then in general, we're putting at least 3 or 4 months between each PICL procedure. Ilse, hi doctor, I have bilateral elongated styloids that are compressing my IJVs. In what sense do styloids hurt my vagus nerve? I'm worried about my vagus nerve being compressed as well, and whether there's compromise in my healing process. That upper cervical treatments, PRP and Prolo, is it possible that the vagus nerve cannot function like it used to for my neck trauma? Can you speak about that? Yeah, Elsie, I don't know how we would ever make that diagnosis, right? I think as I've talked about before in other videos, compression of the internal jugular vein is common. It occurs, so let's see if I get these numbers right. Unilateral moderate compression occurs in about 1 in 3 individuals, all the way to unilateral severe compression occurring in 1 in 4 normal individuals. And then bilateral severe compression occurring in 1 in 5 normal individuals. So usually compression of the IJV as seen on something like a CT venogram, which is how that's most accurately diagnosed, meaning I wouldn't trust ultrasound to diagnose that, is not a problem, meaning that patients are functioning just fine with that. So we have to be careful about that component. And then as far as hurting the vagus nerve, again, I don't know how to get to a diagnosis of someone's styloids are compressing their vagus nerve because, as I've already said, 96% of patients with elongated styloids have 0 symptoms at all. So there'd have to be other symptoms that would make us think that the styloids are a problem. So, for example, specific issues at the back of the throat or with the tongue could maybe lead someone in that direction, but there's a lot of overlap with other problems too. Sharon, I had Centeno, I had a thyroglossal duct cyst surgically removed. They removed the middle part of my hyoid bone. The cyst was attached to, and they probably cut the muscles to get this done. You don't know about a CCI cause, Sharon, but it's certainly not super helpful, right? Because that's all that those anterior strap muscles that we were talking about being involved in this anterior neck stabilization system. It's been advanced by Ruth, most effective diagnostic imaging tool. I think I got that one already. I think you mean about the topic we're talking about, so thanks. Monica, can someone just have Eagle syndrome and not CCI? I have only symptoms on my left side. My left side is elongated, calcified. It's certainly, definitely possible to have Eagle syndrome and not CCI, meaning that we're only talking about patients that have both here. And there are certainly patients who might just have one or the other, and one of those being Eagle or Eagle syndrome. And Monica, certainly it would be helpful to know that one side is calcified and you've got symptoms on that side. But that's a 50-50 chance, right? We have two sides. So if we just looked at random stuff there, we'd have a 50-50 chance of getting that right or wrong. So I don't think we can use that it's on the same side as the calcification as an indicator when 96% of the population with elongated styloids don't have any symptoms at all. It certainly adds a little more weight to the diagnosis that it's on that side. But then you got to add a bunch of other things, and you've got to weigh the risk of not really knowing whether or not it's Eagle syndrome until we do a very invasive surgery. And then we see if it goes away. So be very careful with that. Diana, hi, Dr. C. Can you elaborate more on the ideal time between PICLs? I'm getting one at 4 months. Might be entering a dip now. My 3-month time, my dip is resulting in decreased proprioceptive dystonia and being able to be upright longer. Yeah, I think 4 months seems to be a good timing. I would say 3 to 4 months, we really get to the 3. And I think as I've relayed before, because of the pandemic, we had a very interesting experiment happening, right? We had a large section of people that were in the middle of getting these PICLs who couldn't come in, or they were delayed in coming in. So sometimes they were supposed to be scheduled for 4 months, and instead they didn't come until 9 months or 12 months or 18 months, whatever it was. And we saw about half of the people maintain their gains during that time. About half of the patients really backslid. So, you know, I know that's a hard answer because you don't know which half of patients you're going to be in, but it kind of taught us that if someone needs a second treatment, we should probably have that treatment be fairly regular to prevent that backsliding in half of our population. Nick, does PICL still have good outcomes after a patient has already had styloidectomy? You know, Nick, I don't know the answer to that one yet because we don't have a lot of patients who have had styloidectomy before. I would say in my patient population, and I have the largest PICL population, meaning I do probably 70% of the PICLs in the office. I think Dr. Schultz does maybe 20, 25%, and Dr. Pitts does the rest. Even in my population, which is going to be right now, let's see, you know, growing by hundreds of patients a year, I would say that I only have a handful, maybe 10 or 15, that have had styloidectomies before their PICL. So it's hard for me to say. I can tell you that it is a concern of mine, and that's the reason for doing this video today, right? It's a concern that anything that's done to decrease stability in any part of the neck is probably not a net positive for someone with instability. It's been advanced by Ruth. Does compression of one IJV affect blood flow, or will the other IJV compensate? In general, the other IJV compensates just fine, which is why we see these studies where we've got incidental finding of what appears to be moderate to severe IJV compression, and patients are functioning just fine. So that's one of the things I always tell patients about IJV compression, because we see patients get IJV compression and they get very concerned. And once they get that diagnosis, they're instantly on the internet looking up this and that. But that needs to be tempered with the concept that there's a lot of people walking around out there with compressed IJVs that have no symptoms at all. So thanks for that question. I wish I could pronounce that first name, but I'm not even going to give it a shot. So M. Hi, Dr. Centeno. I've had pain shooting down from my right pelvis to my right foot. In addition to constant cramp in my foot, paresthesias, allodynia, muscle atrophy, and I think there's more there. So M, I'll see if I can catch it down here. Here it is. Paralysis of my right leg. A surgery is done on my lumbar spine is clear, but there's a minor impingement of my L4. I have a C5 disc prolapse not causing any problem. I tried to make and trying to catch all your different comments here. an appointment with you, but ended up having virtual with Dr. Schultz that believes the cause of my L4. I've done cortisone injection on 4, but ineffective. Can you look at my files before I make an in-person appointment, please? Listen, if you didn't get an answer that you found satisfactory from Dr. Schultz, happy to try to do a telemedicine with you. Again, I put my email in the comments here, so just send me a line, drop me a line directly, and I'll try to make that happen. I can certainly give you my 2 cents and try to see if I can help you figure it out before you did an in-person consult. It's been advanced by Ruth. What's the biomechanical purpose function of the styloids as it provides CCJ stability? Yes, if you look at the styloids, really what you have is an anchor point where ligaments and muscles attach. And it's one of the anchor points out laterally of the head, right? So why would you have an anchor point out laterally? Well, it would be to stabilize the head in this position. So it's stability for the head in this kind of motion. It's kind of in the middle, so it's not going to do a lot with forward and back motion, but it is going to do quite a bit with rotation or with side-to-side motion of the head. So the styloids would be an anchor point for the skull into the cervical spine, and in this case, into the anterior neck stabilization system. Aaron, what instability does removal of the styloids create, and does it affect both the head, neck, throat swallowing as well? Well, we know that the strap muscles are involved in swallowing, so it could impact that. And again, I think I've talked about that now a couple different times. It's going to impact that anterior neck stability system. Darcy, I've had Eagles and CCI, had Doppler ultrasound looking at only 20 degrees, cuts off jugular and create spontaneous CSF leaks. In this case, should I remove styloids first? Yeah, Darcy, I wouldn't trust ultrasound to diagnose anything with regard to internal jugular vein. I think it's an inferior technology because it's highly dependent on the operator. And so if you've got an operator with good skills, you might get good information. If you've got an operator with poor skills, you're going to get bad information. So the only test I look at is a CT venogram. And then, like we talked about, you're going to see high rates of internal jugular vein compression in people with no problems. As far as can you go from an ultrasound to this is causing spontaneous CSF leaks, I don't think you can make that jump. I think that's a jump too far personally. So it sounds like someone needs to look at all of this information and try to help you sort through it, because we're focusing on one small bit of information that may not be all that reliable, i.e. an ultrasound of the internal jugular vein. And from that, an entire theory about what's wrong has sprung up. Might be right, might be completely wrong. But it sounds like looking at all of the information in its totality might be needed to see whether or not that's a good direction to go down or just a rabbit hole. It's been advanced by Ruth. Is ossification part of aging? Is there any way to reverse? It is part of aging. It's part of long-term stress in that area. And is there any way to reverse aging? No one's figured it out yet. I'm sure at some point in the future we'll have something really cool that will do that. But here in 2024, it is not possible to reverse aging. Jason, is there a DMX option to be done while laying down? I've seen such amazing results since my PICL. Thank you. Can't thank you enough. I just have 6-7 pain lying down still. Jason, there really isn't a good way to do a DMX laying down. It could certainly be tried, and you could go through the movements, I think. The hard part's going to be interpreting what all of that means, because we don't have normals for patients lying down. So we won't really know what the information means if we could get it. Best of RuneScape. I need to have jaw surgery. Would you recommend doing jaw surgery before starting injections, or stabilize neck first before jaw surgery? I'd have to know a lot more about why they want to do jaw surgery. So that sounds like something a telemedicine eval would be best to help look at all the information in its totality and to try to provide some direction there. Casey, I've had a flat T-spine and your injection done to C6 to help me restore thoracic kyphosis and reduce CCI symptoms. Thank you. Is the anterior longitudinal ligament ever injected for this purpose? It can be, Casey, but to get to it, you'd have to go through the intervertebral disc, and that's going to add a layer of risk that is probably not worth it. Obviously, that risk has to be assessed in every individual patient. Zigzag, how is a malrotated C2 fixed? So realize, and I always tell patients this, C1, C2 rotation can be normal, meaning if you've got scoliosis, you're going to have C1, C2 rotation. C1, C2 rotation might be causing symptoms because of instability or something else, but just be careful because, for example, a lot of patients have scoliosis, and if you've got scoliosis, side bending in the spine, based on the physics of the spine, always results in rotation. So you're going to have a rotated C1, C2, for example, if you've got scoliosis. So be a little careful. It's not always abnormal. It may just be normal for that person. Regenix, been advanced by Ruth. Would PICL fusion correct alignment possibly making a styloidectomy unnecessary? Yeah, I think the goal of any stabilizing procedure in the upper neck would be to reduce the instability, which is causing compression of neurovascular structures anteriorly. So that's why sometimes they'll do a styloidectomy and try to shave down the front of C1. The problem is we're really doing quite a bit of damage to multiple structures. So it would be far better to try to stabilize the anterior neck if that's a problem. May not be. But if that's a problem, you want to take care of that first before you start doing big surgeries where you are removing parts and pieces. Audie, I've had MRIs, upright MRIs, DMX, Dr. Postaway, etc. My question is, what can a cervical rotation CT show that imaging I've already had cannot? Probably very little, Audie. So I usually don't recommend rotational CTs in my patients because I find that they don't add a lot over what you've already had. So if you've got good upright MRIs with flexion and extension and a good DMX, then you're probably not going to get a lot more information out of a rotational CT scan. Kimmy, how do we address tight strap muscles other than waiting for stem cells to tighten up ligaments? Is there a particular PT that could address these specifically? Yeah, Kimmy, I think I would start. Those are my crazy dogs there, guys. Sorry about that. If you want to try to find a good physical therapist to work with, look at IPA physical therapy. That would be a good one. So if you just type in IPA, like the beer, physical therapy, that would be a good one. Ilse, hi Dr. Centeno, I've had bilateral elongated styloids that are severely compressing my IJVs. I think I've answered that one. So Ilse, we probably don't know that that's causing symptoms, but I think I recommended that that's part of telemedicine. Harsh, does pneumoarthrosis of the D spontaneously go in on its own? Doesn't need to be treated if it doesn't cause symptoms. Probably doesn't need to be treated if it's not causing symptoms. Isabella, following up on a question from some time ago regarding red blood cells and lysate, if there's an adverse reaction, increased symptoms from pudendal nerve, will these go away? Isabella, if there were red blood cells in any platelet lysate, then they would be lysed, just like the platelets. So there wouldn't be any issues there at all. So I'm not quite sure what the question is there. Would you do a PICL for the following? I have pain, fibromyalgia, itching, gastrointestinal problems, the muscle twitching. Word PICL might be too much for the body and not work well. I wouldn't do a PICL for any of those things, meaning you have to have instability. We have to think that your instability is symptomatic. That is that The symptoms have to be disabling. There has to be a reason that you have instability. So wouldn't do a PICL for any of those things unless all of those criteria are met. Isabella, for the negative effects to go away, does it need to be treated with lysate without red blood cells? Yeah, I don't know what you're talking about there, Isabella. Smooth advance by Sherry Scott. Sadly, I was talked into a styloidectomy, and it has definitely made me feel worse, not better. I seem to have greater instability. Does that make my chances of being helped by PICL procedure less? Yeah, in general, it's my belief, still early days, that it does reduce your likelihood of ultimately getting the problem solved. That's one of the reasons why I wanted to have this talk today. Jason, sorry if the questions went through twice. Is there a recommendation to dress upper cervical? I think I got that one already. Hair. My GF has bilateral elongated styloids that are compressing her girlfriend, her IJVs. She worries that her vagus nerve is compressed or irritated by styloids to the substructure healing. I think I've answered that already. Compression in the internal jugular vein is common. Elongated styloids are common. They're both common in people with no symptoms. So I wouldn't be concerned about either at this point, unless there's a specific reason to be concerned about that, and that requires a bigger analysis. Darcy, I have Eagle's syndrome and CCI. If I had Doppler ultrasound, it shows looking down at only 20 degrees, it complete cuts off jugular internal artery. In this case, we recommend styloidectomy first. Again, Darcy, we don't use Doppler ultrasound at all to diagnose Eagle's syndrome or internal jugular vein compression, simply because it's highly operator dependent. And so I don't use that data at all. The only data that we would use would be a CT venogram. So I wouldn't act on the Doppler ultrasound information at all. And then you need a bigger analysis, right, of is that likely causing your symptoms or is something else likely causing your symptoms? But you wouldn't want to go through a massive irreversible surgery that will destabilize your anterior spine and your neck until you're absolutely certain that that's causing your symptoms. And I wouldn't use Doppler ultrasound information at all. And for anyone who I've talked today about pinging me via email, that's my email address in the comments. Kimmy, would liquid B12 drops be beneficial to add to daily vitamins? What I've read is very good for nerve fibers and myelin sheath. No, just take a good B multivitamin. I think you're good. Darcy, it's caused spontaneous CSF leaks. Yeah, Darcy, I don't know that we know that. I certainly hear you that's one theory about what could be causing spontaneous CSF leaks, but it's hard to make that diagnosis with any certainty. Let's see, I'm trying to go through these because we're getting towards the end here. If C1, C2 are rotated out of alignment, could that affect the ADI and overhang measurements on DMX? Not really, no. It might affect overhang a little bit. One might be more than the other, but not in a big way. Hair, she had upper cervical treatment, but we think that her vagus nerve might be irritated with the styloids too, that are functioning of her vagus nerve was compromised. Could you speak to that? Yeah, so hair, a lot depends on what was treated in the upper cervical spine and what type of instability. So there'd be 8 different types of instability. Only one of those types of instability would respond to upper cervical PRP and Prolo. Then we'd have to get into what type of upper cervical PRP and Prolo. Was it simple ligament injections? Did they get into the upper cervical facet joints? Did they use X-ray guidance, contrast confirmation, digital subtraction angiography? So lots and lots of different things to look at there. And again, vagus nerve irritation can certainly be an issue in these cases, but it's also sort of a vague box that a lot of things get put into that may or may not be related to the vagus nerve. So for example, I might have GI problems. There's 100 things that cause GI problems, and the vagus nerve can cause that too. Do you do adipose stem cells? Lucy, we've done them in the past. I don't do them on a day-to-day basis at this point because I didn't see an advantage over using bone marrow. And a liposuction is a much higher risk procedure than a bone marrow aspirate. So I've kind of not used that on my daily practice, but we have lots of colleagues that do. Kate, I've removed gluten from my diet. I have PRP with Dr. S scheduled a few years. Dr. Schultz, I understand, right? We want inflammation as part of that healing. Kate, we want acute inflammation. Now, listen, I don't know what the specific issues are with you and gluten because I don't know your clinical scenario. Having said that, I think this is a good question because it talks about the difference between acute and chronic inflammation. Acute inflammation is normal, right? We all get acute inflammation if we injure something, and that's how we heal. Chronic inflammation, which could be related, for example, to gluten insensitivity, is a not good thing. It actually inhibits healing. So we wouldn't want to reintroduce chronic inflammation. Harsh, is it possible to wear a lead vest during treatment? It is. Sure, that's just something you could certainly ask, but that's an easy thing to do. We've got more lead hanging around any given day that we know what to do with. Chaos, what is your opinion on extracorporeal magnetotransduction therapy regarding ligament healing and CCI? There are German CCI patients claiming to entirely healed and overhang up to 3 to 4. Yeah, I've got no idea on any of that. Do I think that it's possible? Probably not, but listen, it's conservative. I'm assuming it's conservative. It's not something we have here. So certainly worth giving a shot to and see if it's not expensive and see if it helps. I think the biggest problem that I see is that I see lots of patients get down these rabbit holes of they're chasing Lyme disease and that's going to heal their CCI. They're chasing mold and that's going to heal their CCI. They're chasing things like this. They're chasing Eagle syndrome. They're chasing posterior injections. They're chasing this. They're chasing that. And these are all low likelihood things based on my experience in helping CCI. And so if it's inexpensive, I'd say give it a shot for sure. Or if money is a no object, and there are certainly patients like that, they don't really care. They just want to try it. So therefore it's low invasive, then give it a shot. But where I see these things tend to cause problems is people get down these rabbit holes. They go from one to the next, to the next, to the next. And before you know it, whatever resources they had that could get focused on trying to help them get their CCI stabilized are gone or mostly gone. So just be careful with that. Sharon, can intubation cause CCI? Certainly in an EDS patient, I would think it's possible. Just because having done a lot of intubation early in my career, you're supposed to, as awful as this sounds, suspend the person's head through that tongue blade. And then you were supposed to be able to manipulate that person's head to be able to get a clear shot so that you can then introduce the ET tube. So yes, that can certainly cause problems, especially in EDS patients. Okay, guys, I think I'm just trying to see if there's any new questions in here I haven't gotten to because we're getting close to, or we're over the hour. Let's see. Interesting one. Sharon, a friend of mine, got her upper neck and skull fused, yet her skull is still sliding backwards and neutral and not doing better, made it even worse. Is there something she can do? Yeah, Sharon, we haven't had good success in helping people who have had fusions already. That's one of those things where the success rates for what we do go way down. Now, we can certainly treat things, secondary effects of that, adjacent segment disease. So, for example, for her skull to still be moving, it sounds like the fusion failed. So it might be possible, for example, to help the 0-1 joints, but that's one of those scenarios where it gets really hard to help people. Hair, how do you know which CCI subtype I have? Does your clinic diagnose that through imaging or tests? Yeah, here. So that's determined based on a telemedicine, and then obviously further determined based in the office. So that's the first step in figuring out what that person needs, is figuring out what type of CCI they have. Casey, have you seen patients with gastroparesis improve after PICL? I have. Yeah, Oleg, I looked at it briefly. It looks certainly very interesting. I think, again, it's a conservative thing. So if you want to give it a try, as long as you don't spend huge amounts of money on it if it's not working, I would say, yeah, give it a try for sure. It looked very interesting. So thank you for that recommendation last time. Okay. Healing lad, Higher Centeno, what would extreme ear pain from chin tucking indicate? Could it be styloid related? I've had it since a minor neck injury. Well, it depends on where the pain is, but for example, one thing that comes to mind is 0-1 facet joint injury, which is what's involved in doing this or tucking your chin. Obviously, if the pain is up front, could be an injury to the longus capitis. If the pain is in back, could be an injury to the PAOM. So lots and lots of different things. The thing that I wouldn't think about would be styloid in that case. Okay, guys, I think that's about it. There's a bunch more questions I didn't get to, but we are at like an hour and 15 minutes, hour and 15 minutes. Okay, so today's topic, as we have been discussing, is about styloidectomy. I appreciate everyone being here. There are no bad questions. Definitely had tons of questions today, more than I could get through in a single hour. But I gave it a shot. If you've got questions that you didn't get answered this time, we'll be back next weekend on Sunday. Just pay attention to the time there, and you can certainly roll those forward to the next topic. I'll be back with another topic next week. And again, if I have any parting words on styloidectomy and Eagle syndrome, big surgery, common problem, elongated styloids, rarely symptomatic. And so it's a big decision to make on a big surgery where you've got to be really certain that that's causing your problem. And it gets concerning to hear that 96% of patients with elongated styloids don't have any symptoms. So just be careful there in making that decision, because it does have impacts. It has impacts on stability of that anterior neck, which is what we've been talking about. So thanks so much for all your great questions today. Again, the focus here is there are no bad questions. Questions only help us to get to answers, and the more questions and answers people hear, the more they learn. So thank you so much for participating today, and we'll be back next week with another topic, and then hopefully more great Q&A. So thank you and have a great week.